Hi, in this pre-conference video, I'm going to go over pain pathways. So before we get started, I really want to go over some of the basic terminology and discuss to you some of the basics that are important for us as we get into the clinical management of pain. So one of the most common complaints patients have is that they have pain. Now, there's people that have inflammation that causes pain, and there's people that actually have pain syndromes where the amount of pain they have does not make sense to the degree of injury or to the degree of inflammation. So those are the two main camps, just people that have inflammation and people that have an unproportional response to pain, which we have issues related to pain syndromes. So what I did this video is really discuss nociception, how C fibers, A delta fibers activate the pain pathways, the impact that's happening in the cortex, descending pathways, the central mechanism of pain, and all the different things that activate nociceptors, just as a basic review before we get into the clinical information in the actual course. So the first place to start is just the definitions and types of pain. So for pain itself, pain is an unpleasant sensory and emotional experience associated with actual potential tissue damage or described in terms of damage. So if everything is normal, in order for pain to take place, you have to have something that activates a nociceptor, and then that degree of activation of the nociceptor should equate to the degree of pain that a person has. And pain is actually considered an emotion. It's not one of our primary senses like smell or taste or sound. It's unpleasant sensory experience that is generated by nociceptors to the parietal lobe and has an unpleasant emotional response in the limbic area. This is important because when people have pain syndromes, there's an unproportional response that takes place from pain. Nociceptors, those are the pain receptors, so high threshold sensory receptors of the peripheral somatosensory, soma being muscle, joint, ligaments, sensory being nerves. Somatosensory nervous system that is capable of transducing and encoding noxious stimuli, right? So a nociceptor gets depolarized, gets activated, activates areas of our brain. We notice the pain and we have an unpleasant emotional experience with the pain. That's parietal lobe, that's nociceptors, and that's limbic system. And then hyperalgesia is increased pain from a stimulus that normally provokes pain. So that would be like you would expect some pain, but it's exaggerated, right? So if you're using like a pinprick pinwheel, if you just stroke someone and they're really, really sensitive to it, that's hyperalgesia, all right? And let me just skip neuropathic pain and just go to allodynia. Allodynia is pain due to stimulus that does not normally provoke pain. So for example, if you took pinwheel, pinprick testing, where you stroke someone's skin with a pinwheel. Everyone that you do this test to, they will probably go, yeah, I feel this pinprick, it's not pleasant, but yes, I notice it, and it's the same from, let's say, right to left. Hyperalgesia would be you do the pinprick test, and on one side it's extremely, extremely sensitive to them, and they feel pain. So that's hyperalgesia. Allodynia is like you touch their skin and they have a pain response. So you would expect that a pinwheel, a pinprick sensation would cause pain because the small amounts of surface area with pressure activate nociceptors. But let's say a large surface area, soft area like your finger, if you just stroke them, shouldn't cause pain. If it does, that would be allodynia. So we have a normal nociceptive response of just like, oh, I feel the pinwheels. Yeah, it's kind of the same. Hyperalgesia, it's really exaggerated response one side. Allodynia, you just need to touch it and use something with large soft surface area and they feel pain. So those are the different types of pain patterns. And then neuropathic pain is pain caused by lesion or disease of the somatosensory nervous system. And you can have peripheral neuropathic pain, which is like receptors or tissue injury, or central neuropathic pain, which is areas in the brain have developed a pain syndrome, just like people have, like for example, phantom pain. Phantom pain is a central disease. It's a person has their arm cut off, but they still feel their thumb burning, even though they don't have a thumb anymore. So those are central neuropathic pains. And so anything involving the brain is central. Anything involving spinal cord out is peripheral. And then sensitization is increased responsiveness of nociceptive neurons to their normal input and a recruitment of response to normally subthreshold inputs. So you can hear the word hyposensitization, hypersensitization. Hyposensitization means like you stroke them with a pinwheel, they don't feel anything, and then you have to really dig in until they've really noticed it. So that means their nociceptor neurons are far from threshold. It takes a lot of activation and pressure to fire them. versus some neurons are very close to threshold. They're hypersensitive, just a little bit of touch gets them exaggerated. And nociceptors, for example, can be sensitized by chemicals. Like if you have someone who's got an allergy response and they have high amounts of circulating prostaglandins in their body, then they may notice like a pinprick sensation with a pinwheel or mechanical stress to their joints much more aggressively than when they don't have prostaglandins from an allergy elevated, because prostaglandins activate nociceptors from a chemical point of view. So if you have chemical activation of a nociceptor with mechanical, then the pain can be much higher. And at the end of the day, as a clinician, you have these nociceptors and you got to figure out how are they expressing? Is it something that's driving these nociceptors aggressively, or is it the response of the brain that's impacting these nociceptors, or is it a combination of both? Now, there are chemical triggers for nociceptors. So we just talked about prostaglandin imbalances. So people that have an imbalance in their essential fatty acid pathways, people that eat lots of partially hydrogenated fats and unhealthy fats, or fats really high in, like fats from food sources that are high in arachidonic acid, like shellfish and red meat, compared to anti-inflammatory prostaglandins from things like olive oil or flaxseed oil or fish oil. So when people have an imbalance in their dietary fatty acids, they can get prostaglandin imbalances, and prostaglandin imbalances activate nociceptors. Hypothyroidism has been shown to sensitize and make pain fibers respond to pain much more aggressively. Local inflammatory response. Maybe someone has an injury. Maybe they tore their meniscus or tore their L5 disc, and there's just an injury there that makes them very sensitive to any kind of activation. Adipokines from obesity have been shown to cause more pain. So body fat itself releases adipokines, and especially with insulin surges. So insulin surges, especially in someone who has obesity, can increase their circulating adipokine levels. That can increase pain. Catecholamines, stress hormones. So whether it's from constantly smoking, whether it's from constantly having blood sugar levels drop to raise catecholamines, any kind of physiological stress response or emotional stress response can increase catecholamines. That can make pain fibers more sensitized. And these nociceptors we're talking about are both in the peripheral tissues and also in the brain. Glycosylated end products, people that are diabetic that have an issue controlling the blood sugar levels, they can have some increased pain perception. Glycosylated end products activate the RAGE response, the receptors for advanced glycation end products. That makes nociceptors much more active. Dysautonomia, people that have exaggerated sympathetic responses and can calm down their heart rate, their pupil response. They have heart rate variability. They have increased pain perception. Certain toxicants and chemicals have been shown to increase central pain sensitization. We'll go over those in the course. Lack of oxygen, hypoxia to tissues can increase central peripheral sensitization. So people with very poor circulation end up with more pain syndromes, especially in the limbs where they have an injury, where they don't have good blood flow. Insulin surges, unrelated to obesity, but insulin surges themselves can increase nociceptors, so they're more sensitive. And then increased free radicals, not enough antioxidants can be a factor there. Autoimmune diseases that really impact sensory ganglia themselves, sensory tissues, brain can cause pain disorders, both peripheral and central. Neuropathic pain disorders. Lack of cortisol. Cortisol has an anti-inflammatory response. People that just stop producing enough cortisol throughout the day because of fatigue issues, and we call adrenal fatigue issues, or we see low cortisol output throughout the day. They can have increased central and peripheral sensitization of pain. So one of the things we always want to do when we look at someone who's got a chronic pain syndrome, in addition to figuring out what their pain is, what caused their pain syndrome to begin with, is if it's persistent and it's ongoing, and that this hyperalgesia or allodynia, if any of these factors are involved, to what degree, because these are things that we may have to control. Like you could have a person who has a back injury, but they just can't get out of chronic pain because they have a prostaglandin imbalance because of the way they eat healthy and unhealthy fats, and because they also let their blood sugar levels drop. So let's say you take a hypoglycemic patient who's just eating, chips out of a bag all day, or veggie chips that are partially hydrogenated all day, and misses meals, and then has a high sugar smoothie, and that's like their main meal, and they don't have healthy amounts of fish and healthy fats and olive oil and nuts and seeds in their diet because they're fat phobic, they can be in a chronic pain pattern because of some of those various mechanisms. So we'll go over those in more detail in the course, but this is just a list of various triggers that activate nociception. And then when you look at the neurology of pain outside of what chemicals impact pain, basically you have C fibers and A delta fibers. And C fibers are unmyelinated, so they don't have a myelin sheath, so they're much slower. And then you have A delta fibers that are much faster, but they basically nociceptors in our peripheral tissues get driven by these fibers to the cord. In the posterior horn of the cord, we have our sensory perception, and then these pain fibers cross into the spinal thalamic tract to the opposite side, usually 1 or 2 segments of it. They come into the spinal cord and then go all the way up from spine to the thalamus, hence the name spinal thalamic tract, to the cortex. And in particular, they go into the proprioceptive pathways in the cortex, in the parietal lobe, in a somatosensory orientation. Remember, like the somatosensory map. So in the inner part of our parietal lobe, we have a representation of our feet, and then our face, and then as we get down, it's our arms, and then, the medial part of it is the legs, then the face, and as we get down to arms, all the way down to the strip of the parietal lobe. So that's how these fibers project into the cortex. And the basic pathways, like tissue injury, activates alpha delta fibers, goes into the spinal cord, the spinal thalamic tract, crosses at the spinal cord level, goes all the way up the brainstem, goes to the thalamus. From the thalamus, it goes into the parietal lobe, and you have the activation of pain pathways that way. Now, there's a medial and lateral pathway up to the spinal cord. The lateral pathway, the spinal thalamic pathways, is where you have, like, I feel pain in my right hand. I feel pain in exactly my right toe. They can kind of localize the area of pain. So this is the spinal thalamic pathway. There's another pathway for an ascending pain pathway, where it's involving the medial projections, and input from pain fibers go into the brainstem, and they activate the frontal areas, the cingulate area in particular, and the amygdala, and this is where we have the emotional response to pain. So it's totally different than if someone says to you, I feel pain, I just don't know where it is. That's a lateral pathway. Or they experience pain and they go into an emotional crying event, an emotional response or an anxiety response when they trigger pain. Those are 2 different neurological pathway projections. So you should know that these can occur. So some people have central pain disorders. Their pain causes significant anxiety, heart rate variability, autonomic dysfunction, emotional responses, and those are things that let you know that there's a central-based limbic, meaning emotional, pathway involvement. And then those that, for example, know there's pain, but they just don't know how to localize it and where it is, and those are what's, for example, people have parietal lobe injuries, parietal lobe strokes. So that's important. Now we're going to go through in the course step by step your history, your clinical evaluation, and then you're going to determine which variables are impacting nociceptor activation to making them more sensitized. Is this a lateral ascending pathway? Is this a medial ascending pathway? And then we'll talk about descending motor pathways too. But the key thing is for someone to have chronic pain and that's not reasonable, that's unproportional, there's something happening with either nociceptors or an exaggerated response in these central-based pathways. So things like past brain injuries we talked about, like neuroglia priming in the neuroinflammation course, people that start to have neurodegenerative changes with cognitive decline, they can actually have some degeneration in areas of the brain where these neurons are close to threshold and they have an increased response to pain. So those are all ascending pathways. Now, the brain itself is also involved with dampening pain perception. And the descending main pathways go from the cerebral cortex primarily to an area of the brainstem and in the midbrain called the periaqueductal gray, and then that has descending inhibition pathways to the spinal cord. So here's, like, for example, the brain. The descending pathways involves the brain activating this area in the midbrain called the periaqueductal gray. That's right in the middle of the surrounding the cerebral aqueduct. And then these pathways then have a serotonergic pain inhibition pathway in the posterior horn where A delta and C fibers come in. And when people lose their brain activation, just the overall state of brain function, they many times lose their ability to activate their periaqueductal gray. And to say it in a different way, your degree of brain function, your brain integration, has a significant association with how much activation you have in your periaqueductal gray. So when people have things like depression or things where their brains are not firing very, very well, for whatever the reason may be, maybe it's a neurochemical imbalance, maybe it's a blood sugar issue, maybe it's a neurodegenerative disease, maybe it's trauma to the brain. But when the brain isn't firing like it should, the frequency of fire of the brain is reduced in the cortex areas, then there's descending input to the periaqueductal gray, which means they can't dampen their own pain, so they can have increased pain perceptions because their descending pathways aren't working. So here's an illustration that was done by Dr. Newcomb Daphne at UT Medical School Houston, and they kind of just show activation of this periaqueductal gray. Now they're using electrical stimulation, and you can see here as they do electrical stimulation, like in a study and how things work is these periaqueducal grays fire. Now normally it's not electrical stimulation. Your cortex, the degree of activation of your cortex is activating these periaqueductal gray areas, and then these periaqueducal gray areas are releasing these blue and purple like compounds, which are endorphins and serotonin type responses. And then these serotonin dopamine responses then have an inhibitory pathway. So I'll show you this video illustration that he also made, and at first it shows you like the hand getting injured, alpha, A delta, and C fibers carrying pain into the spinal cord, posterior horn crosses into the spinothalamic tract. Spinothalamic tract goes into the ventral posterior lateral thalamus, into the cerebral cortex areas, and that's where you have pain perception. And then some of these projections go into the limbic area where you have the emotional unpleasantness of pain. And then it'll show you activation of the periaqueductal gray, which inhibits it. So this is the ascending pathway in red and descending pathway in purple. There's nociception triggered. Nociceptors were fired. It's going up the spinothalamic tracts, being perceived in the brain as where the pain is, unpleasant experience to pain, and now you can see the purple activation. The cortex itself would normally fire into this periaqueducal gray, releasing endorphins and serotonergic projections that have inhibitory pathways into this posterior horn, where nociceptors or pain fibers come in. So this is the balance that we have. So whenever we're looking at someone who's got a chronic pain syndrome, we always ask the question, are these nociceptors activated by chemicals too aggressively? Are these neurons close to threshold or degenerating or injured in the parietal lobe? Is there issues with the health of the brain, frequency of brain that impact descending pain pathways? And those are the things to look at with ascending and descending central pathways for pain control. Now, another concept with pain is what's called gate theory. And gate control theory is, for example, if you, let's say, accidentally hit your fingers with a hammer and then you start to shake your hand, that helps get rid of pain. And this is what you see all the time. When people get an injury, they'll just move their limb. And part of the reason is because movement of the limb activates mechanoreceptors, proprioceptors, you may rub the area. And proprioceptors, mechanoreceptors are myelinated, so they're much, much faster than C fibers. So these mechanoreceptors inhibit pain pathways at the spinal cord level. That's called the gate control theory. So boom, injury, pathways going up to the brain. This posterior horn is where this nociceptive input is first. Person rubs it, mechanoreceptors come in, and they gate pain pathways. So that's called gate control pathways. So you can have a pain inhibition pathway locally through the spinal cord. This is where things like E-stem, things like acupuncture, manipulation, massage, stretching can impact pain through this gate control pathway. And then you also have gate inhibition, remember, through the midbrain. The midbrain pathways also fire to the same areas in the posterior horn of the spinal cord where you dampen pain. So that's one of the things that you're always looking at when you're looking at pain path, when you're looking at how different therapies, different mechanisms control pain. So here you can see again, C fiber coming in causes pain, and then mechanoreceptors are highly myelinated. They come in, they have this ability to inhibit neurons. That's why we move and rub our hands and shake things when a person has pain. And then in summary, when you're looking at the mechanism of pain fibers again come in, they activate the posterior horn, they go all the way up to the brain, they activate different areas of the brain, the cingulate areas where we have the unpleasant experience of pain, the emotional limbic response of pain. The parietal cortex is where we localize where pain is. Then we have areas in the midbrain that descend through the periaqueductal gray, you see here in green, that then go down and inhibit this. And then we have a gate mechanism at the spinal cord level to dampen pain. So when someone has chronic pain, either these central-based mechanisms aren't working, which would be called central-based neuropathic pain, or these peripheral receptors are being activated by various things like these metabolic triggers that are causing pain. So what we want to do is when we see someone has a chronic pain syndrome is go pain, and again work our way up and down through the brain, see if those factors are there. We'll talk about how to do an evaluation and examination for those mechanisms, and then also we want to do a metabolic workup to see which of these nociceptive triggers are involved with pain. And usually it's a combination of multiple factors. So we're going to be talking about those in the course. I hope you found this pre-course video useful, and hopefully it can help you, prepare you to take on the load we're going to get into in the course with the clinical information and treatment applications. Thank you.